So I apologize for not being able to, for you not to be able to see my face, but I'm very excited to be able to talk to you today about the value of Chiari research to patients and families, and talk a little bit about the value of patient-centered outcomes as well. Let's see if I can get this to move for me. There we go. So what I'm going to do today is, again, just bring what we consider patient-centered outcomes, questions that we aim to answer as investigators. I want to talk about the value to patients who participate in research of what you bring, and talk about the value patient-centered outcomes brings to investigators as we look to improve and outcomes overall. I want to touch base a little bit on a couple of the patient-centered studies that we've worked on or that are ongoing now. Also step into the Park-Reeves consortium a little bit and talk to you about network, and then kind of resources and organizations of interest be relevant. Some people may not have, but I just thought it was information, and then answer questions. So let's talk about the working definition of patient-centered outcomes research. It allows people to to help decisions, and allow them to also be able to be heard when of healthcare options. When you look at healthcare and you look at patient-centered outcomes, broadly at what that term patient-centered outcomes is very broad. And so from a healthcare perspective, from a research perspective, we look at things like psychosocial issues, socio issues, some health disparities that may arise, issues. And at this, you're not just talking about the healthcare, you're talking about the community-based. You're talking about non-support services. So is it child social work? Is it nutrition? There are other things that need from a support service standpoint to help and then of course broadly in population health. And then you also have to look at end of life care. So when we can't forget about the arena, and that's just as important when you look at patient-centered outcomes, having a voice of decisions. So from a research perspective, some of the questions that I think are relevant to ask the following: so characteristics, conditions, and preferences to happen to me. I think a risk is not discussed, or patients walk away with a different, maybe what we need them to have procedure or making those decisions. Sure that we can answer that question. What are the benefits and risks that I should be aware of when options? We want to make sure that we to utilize in the in particular diseases like we don't have necessarily information yet. We're starting to come together as networks, making these decisions, looking at standard and redefining what that looks like from a physician research standpoint and from a patient. That becomes a really important question to patients and families. What can I do to improve? Most important to me. So it's hearing this question as a surgical world, or know how they can participate in care, and it's a little post that discussion about what the diagnosis is, and so we need to make sure that we circle back and really start to address that with our patients and families so that they can actively participate in their decision making and in their care overall. And this is really important when you look at things like readmission rates and infection rates. We want to make sure that we can disclose to them and encourage them to participate in what they can do to ensure that they don't have unplanned readmit unnecessarily, or an infection that occurs that has to be treated. The other question, and there's lots of questions, these are just several that I thought would be worth touching on, is how do clinicians help me determine the best decisions for my current health and future health outcomes? So I think this is a really interesting question, and something that as we start to look more at works and consortiums that come to the world to make care, I think this becomes a much more important to discuss, and to let our families know a single institution, single surgeon type of situation, that this is a consensus, or these are guidelines that have been developed, or recommendations that are being evaluated, compliance that we look at, or quality improvement type things that we look at now. I mean, these are all things that are relevant to making our patients understand that we're providing the best care and best practice decisions. A little bit about why patient-centered and what the value is. So from a patient and family perspective, there's been some research that's actually been done on this. And when they were asked why they participated in research, several families, actually about 60% of the families in several of the studies combined, said that increased knowledge, awareness, and information about their diagnosis, treatment, and management was the main reason why they participated in research. Another reason is sense of community, benevolence, and pride of completing the study. So a little bit, I had to think about this a little bit, but it makes a lot of sense when you think about sometimes participating in research and giving your opinion or providing your feedback isn't necessarily going to help the patient right then, but it's going to help the patients down the road. And I think that that's a great way of providing a sense of community, is being able to help the next person who's diagnosed as well. Perceived risk, expectation of outcome, and satisfaction feedback is made easier with advances in technology. So, you know, when you look at how families are perceiving risk and what that means, if they had an expected outcome or not, and if they were satisfied with their care overall, they become very invasive, some uncomfortable sharing what that information to, you know, or disclosing to their. And with today's patients and advances in technology, there are email systems or ways online that you can do anonymous to give feedback. Important, and it's important to understand how those risk, expectation, and satisfaction, not only to the clinician but to the patient, make those things even more clear that we provide them. Outcomes of particular interest to patients, psychosocial, and health-related quality of life. And these are very specific outcomes that are not going to related to, or, you know, surgical technique or, you know, medical treatment. Very patient specific. We, if they're functional, we want to know what their activities. We want to know, you know, is it important? Are you having depression? Are you being able to work now and spend? Is your child able to school, and what does that look like? Symptoms continuing to participation in activities. We want to know those things, and I think it's start to focus even more on those types of outcomes. I was actually reading a study that about 1 in 5 trials now have as centered outcome, and I think to PCORI coming on because of the structure. Patients, participate in outcome studies is to serve as they can contribute, implementation or dissemination of. We want to know if it matters we're studying. We want to know how best out to the community, and do that. How do we recruit patients? That's to our stakeholders and our patient partners. Provide buy-in and have you give feedback for patient. So from an investigator standpoint, I think it's really kind of takeaway message here. A lot of words on the screen, so I'm not going to read them all. Message here is that healthcare is changing. Reimbursement rates are changing. Very important for us to take into consideration patient satisfaction. More importantly is that this holistic view. I mean, the picture at the bottom, the bi-directional center view, where we are getting feedback from the patients. We're having a conversation. We're getting what is important to them. We're how they're taking in information, or how needs to be best educated, or information comes from. Is it online? Is templates work? Is there a language? Just that. We want to make sure that we're providing the best. Participating in these types of studies, us ensure that we provide that to families in the future. And a really important point is we start to understand how we can close the gap with disparities or minority representation, allowing for more generalizability. Research findings, but in our surgical decision making, as we start to do standardization of clinical pathways and standards, we want to be able to make that best practices even more patients and families. So now I'm going to talk a little bit about some of the Chiari-related patient-centered studies that I've read about and participated in, some that have completed and have moved on to different phases, and some that are still ongoing. And there are a lot of neurosurgical related studies that are going on, and there are a lot of outcomes related Chiari studies going on and basic science studies, but these are specific to patient-centered outcomes, and so I just want to make that very clear. The first study I wanted to talk about a little bit is from Greenberg et al. Out of Washington University and St. Louis Children's Hospital. And what they did is several years ago was to assess what outcome methods there are when you look at clinical one. And so tables on the are basically several quality of life instruments that are utilized for our evaluating outcome, and these specific scales that are used to evaluate outcome. And the majority of I guess about half maybe of the instruments are adult focused with a child component, have been adapted in the population. And then with specific, again, the same thing, adults specific adapted or modified version to the pediatric. But what we've found is that there's no Chiari specific and pediatric instrument that basis as a standard of care. And so I think that's very important for us to move forward in redefining some of our definitions and what it means to have Chiari 1, and hone in on how do we best evaluate those outcomes from an objective standpoint, and can we come up with an outcome measure that is validated, that is generalizable across not subspecialties, but across different populations, different countries, different demographics, And so I think that is going to be a really groundbreaking process for us to work through over the next several years. So, excuse me. So, having read through and evaluated that study and been a part of that study with WashU, part of the research done at Vanderbilt was to actually develop a quality of life instrument for pediatrics and patients that were diagnosed with malformation. So we did an incredible amount of work on this, validate this instrument. We had preliminary analysis and preliminary looked at existing instruments out there and tested are effective in picking up the crime that we often have in the and are experiencing on a daily basis. And what we found was that those instruments and many of our Chiari aren't necessarily surgical, so we need to find a way the chronic symptoms that are daily, and how do we have that to identify, address those chronic symptoms. So this study was it's a 45-item instrument. To give you an idea of what this looks like, there are 4 pain frequency, severity, non-pain, and then a psychosocial component. Pain frequency, severity, non-pain, physical domain, and then again, social domain, which ultimately gives quality of life score. And doing at this point, did this in a patient group. It was we're doing right now is we just did the first follow-up study, short-term follow-up, which takes us out about a year. So we've been tracking these patients now for a year, and we're in the process of submitting that for publication and evaluation, but are really showing some great with regards to being able to track quality of life, improvement of quality of life to those that are having serous regression or maybe even continued symptomatology or stable syrinx. So I think that this is at least some great work that we're starting, and I'm hoping that people are going to want to utilize this instrument and really start to tease out the most effective way to use a quality of life instrument in our population. So one of the studies that I found, which I thought was really interesting, specific to the adult population, in the treatment of patients that have Chiari. And so huge push in the United States to really evaluate how and to identify where social determinants of health are and where those gaps are and where we need to really improve from a clinical pathway and clinical decision-making standpoint. So this was an interesting study. What they found was that females often reported more severe symptoms and took longer to seek evaluation than their male counterparts. That's really not surprising to me, actually, because I think a lot of times that females or women of the household may have other people that they're taking care of, and so maybe we tend to put our health last. I'm not really sure, but I find that I do that even with my daughter. Her needs become more important than my needs, and so it may take me longer if I'm sick to go to the doctor because I want to make sure that she's okay first. Patients with public insurance experienced a longer length of stay compared to patients with private insurance. Not really sure what this is, if this is a phenomenon specific to this patient population, or if we're looking at across different regions of the U.S. or North America or Europe, or if we're seeing this kind of trend and what that looks like. Caucasians had a significantly larger syrinx at presentation than did African Americans. Again, I'm not really sure why that disparity exists, but I find that intriguing and something we ought to spend more time evaluating. Females also experience greater upper extremity weakness and more cranial nerve findings compared to their male counterparts. So an interesting study that I think in the adult world we could expand into the pediatric population and start to really evaluate where some of these patient-centered outcomes can best be addressed to reduce the health disparities gap. So a couple of the other studies that I saw that are currently ongoing, which I thought were interesting, is comparing interventions, so a controlled water-based exercise program, to other kinds of cognitive therapy for Chiari patients dealing with chronic pain. Again, I spoke about that earlier, that there's clearly a patient population and patient group we need to address with these issues. And so I find that very interesting and was very excited to see that. Another study currently going on is looking at the development and psychoeducational impact of Chiari. So this is a individual who is a psychologist who is interested in gathering information so that he can develop materials and guides for patients and school officials, actually, to help maximize their child's participation in the school environment. I think that's very interesting, and I'd love to see that because, again, we're getting the community, where there's community stakeholders involved, schools, parents, we're working with the patients, we're understanding the needs and where those patient outcomes are coming in. I'll be interested to see the results of that study for sure. So now let me give you a little bit of background about Park-Reeves, and then a little bit of update about Park-Reeves, and talk a little bit about our trial that we're currently participating in. So the Park-Reeves Syringomyelia Research Consortium has been enrolling since about 2011, and we have a registry of over 1,100 patients currently. There are 29 sites across the U.S. that are still enrolling. We have 342 patients that were listed as retrospective. So with our sites, we had them go back a certain number of years and identify patients that we had our inclusion criteria for enough data and follow-up to include in our registry. And then we had patients moving forward. So they were enrolled at the time of consultation and are being followed. And so you may be involved in one of these studies, either as an investigator or as a patient, and are being followed over time. So again, almost 800 patients we have prospectively that we've been following multiple years. We have 12 studies that are going on. One was recently just published, which I'm going to talk about in just a second. But the one, I think the exciting piece about the registry right now is that we're adding that quality of life piece. Again, we're starting to capture this in these patients. And so you may be asked, if you're a patient or a family, you may be asked to complete a quality of life instrument, and I encourage you to do so. It doesn't take very long, 5 or 7 minutes, and it's really going to be a part of your clinical decision making. Here at Vanderbilt, it's become standard of care, and so our quality of life, the chip, is actually given by our clinic staff, and it's put into the medical record and utilized for evaluation. And that's what I hope to see over time, is that we actually are utilizing these quality of life and patient-centered outcomes in the everyday clinical decision-making process. So this is an Interrater reliability study that some of the Park-Reeves investigators participated in. For those of you who are not familiar with Interrater reliability studies, it's basically assessing, are we evaluating, in this particular instance, imaging the same way across institutions, across the country, across the world. This is very important, again, to going back to what I was saying about standardizing care, finding best practices, identifying guidelines, and doing this as a consortium, as a group, as a expert panel is really important. And so this study was great. It was published. It actually showed, if you look at the table, I'm not sure if it's blurry or not on your screen. It's a little blurry on my screen. But if you look at the table 2, it has a column listed as ICC, which means how correlated were all the reviewers. And if you have a 0.7 or above, that's considered good correlation. And so across looking at CTs or MRIs, it looks like we're doing a fairly good job across the different investigators that participated in assessing PBC2 lines and Syringomyelia as a whole. So we're measuring those, we're reading those fairly good, fairly consistently across our investigators. That's important to patients and families. You know, if you are going from, let's say you're moving from Seattle to Houston and you're having to have your care transferred, you want to know that your surgeons are reading things, that there's not a great deal of variation in care, that you're getting that consistency, and you're being told you understand the same concepts, you're being told the same things with regards to treatment decision making. And of course, that's going to vary a little bit, but I think this is a great first start for us to be able to say, yes, we can come together as an entire group and make some decisions that are standardized for our patients. Within the Park-Reeves consortium, we were funded by PCORI to conduct a randomized control trial. This was a clustered randomized control trial. For those of you who are not familiar with clustered randomized control trials, what this means is you're not randomized per patient, you're randomized by what center you're at. So Vanderbilt is randomized to a certain type of surgical intervention, WashU is randomized to a certain surgical intervention, Columbia or Seattle or Houston or wherever. So it's not by patient, it's by site. And so this particular randomized control trial is evaluating the two different surgical techniques for treating Chiari 1 malformation. Posterior fossa decompression with duroplasty and those without, also considered noted as bone only. So this is a study that, again, is funded by PCORI, and it's supported by several of our industry organizations, the AANS, the section of the AANS, CNS, and CNS. We also have support from patients and families, advocacy groups, and foundation partners. ASAP is one of them. And we also have community advisory boards across the country that are participating in this, as well as additional community stakeholders. So it's a pediatric group, so less than 21 years of age, with a Chiari with greater than or equal to 5 millimeters, and a syrinx of between 3 and 9 millimeters. And then if you've got a greater than 10 millimeter syrinx, you're excluded. And then if there's neuroimaging or you've had a prior decompression or you're not interested in participating, you're also excluded from this trial. So here's the rationale that we thought was important, and this is what we presented to PCORI when we were applying for funding. We thought the impact of this study was relevant. We want to identify which is the best surgical approach to maximize symptom relief, to minimize harm and complications, and to maximize and have the highest quality of life over time. We believe we're addressing a gap, so there's not a high quality evidence-based data that exists for the treatment of Chiari 1 malformation with Syringomyelia, meaning there's not another randomized control trial out there. And when you look at level of evidence, meaning what's going to have the most impact, randomized trials have the most impact when you're assessing relevance to and impactfulness to clinical care. So we're trying to, again, establish best practices by minimizing, patient harm. And then this is, again, I've talked about this a couple of times and touched on it, but this is a paradigm shift away from the individual surgeon preference or center-specific preference. Instead, we're looking at coming together as a group and with a consensus with level 1 data and understanding the risks and benefits between these two surgical techniques. So I won't read through all of this, but just so you understand, the first aim, again, is to understand the complication rate between the two procedures. And we hypothesize that posterior fossa without Duraplast will be associated with fewer surgical complications. And that's within a 12-month period of time. And we've kind of defined what those complications are in our anticipated outcomes. So CSF leak, meningitis, infection, hydrocephalus. Aim 2 is that we're saying that there's no difference with regards to clinical improvement, or there's, sorry, not no difference, that they are the same. There's no inferior improvement or serious regression. So what we're trying to state here is that we think that they are both equally effective surgical outcomes, surgical techniques with regards to clinical outcomes. And we want to be able to determine if that's the case. Our last aim, which again is our patient-centered specific aim, is to determine the quality of life and which surgical technique provides the most or has superior quality of life over time, not just at one time point, but over time with regards to symptomatology, serious regression, and just overall complication. So here's our milestones for this particular study. We have 35 centers that are participating. We've screened over 300. We've enrolled 47. That's a little lower than what we need to be at this point in time, but we've screened a great deal of patients, and so we can't ask for more than that at this point. And several of our centers have just geared up, so we expect to see an increase in enrollment over the next 4 to 6 months now that we have everybody on approved and starting to enroll. And just to go back to our milestones real quick, we do have calls with PCORI every month to discuss our challenges, to discuss the effectiveness of having 35 centers and involved in a study like this. And so at this point in time, PCORI has not been discouraged with what we have accomplished and what we are seeking to accomplish. They've been very encouraging and are very excited actually to have all of these neurosurgery programs involved in a randomized controlled trial and looking at such an interesting group of patients and with regards to symptomatology and quality of life. So now let me just touch on just for a few minutes about resources and organizations of interest. So this was something that I felt was, I just wanted to, spend a few minutes looking into, because there are organizations across the world that are addressing how to determine best practices, how to implement patient-centered outcomes on a daily basis, how to capture those, what those need to be. And so these are just a few of the organizations. Some are international, some are supported, like the Coalition of Quality in Geriatric Surgery is supported by the American Academy of Surgeons. Then you've got the N2QOD, which many people are familiar with, which is a benchmark with regards to neurosurgical procedures that many hospitals are involved with. It is relevant to cost and implications of readmissions. You've got some other centers like the Patient-Centered Outcomes Research Unit at Mass General and the Surgical Outcomes Center for Kids at Vanderbilt that are solely focused on surgery and surgical outcomes and patient-centered outcomes. And so I think that's, a great, it's great to see that these programs are growing and that it's giving us more opportunities for our patients to be more involved and have more of a voice in what we need to be looking at from a research and a clinical standpoint. So this is something, just a couple of things again. So this was a journal that I found, which I had not been familiar with up until now, Research Involvement and Engagement. It's actually a journal that's co-produced by key stakeholders, including patients. And I thought that was very interesting. Had some really interesting articles in there that talked about patient outcomes of interest and studies that were done. And so I would encourage you to take a look. So if you're a researcher or a physician scientist looking to publish some patient-centered outcomes, this may be great. If you are a patient or a community stakeholder, I encourage you to take a look, because this may be some where you can get some of your information, or you could get involved again with the idea of patient-centered outcomes research. And just again, very different from what I've seen out there before. And so I just wanted to bring that to your attention. For our patients and families, if you're not familiar with Research Match, you should check that out. It's a way for you to get involved with research studies. So they will send out research studies from across the country. Some of them may just be surveys. Some of them may be, require other involvement in research, but you could get involved with somewhere near your house, or you could potentially be involved with surveys that are done across the country. So take a look at that. And again, another resource for you just to learn about research and learn about how you could get involved and how your voice can be heard. And then I put an article here, Understanding the Value of Community Advisory Boards. There is a big push and requirement, actually, for a lot of funders now that you have a community advisory board involved with your study. So at Vanderbilt, we have a research community advisory board within our Surgical Outcomes Center for Kids. These are community stakeholders, so it could be community physicians, practice managers, public health officials, school officials, patients and families that participate on this community advisory board. It meets every quarter and for about an hour and a half. And we do all kinds of things, from training on research methodology to having our members review a protocol, evaluate a survey that's going to go out, talk to physicians and researchers about where to recruit and how to recruit certain patient populations. So it's been really interesting and a lot of fun, actually. There usually is a small stipend and compensation required, not much, but most of the folks that are involved with these community advisory boards aren't, looking for a ton of income. They're just looking to be involved and have their voice and have another way to share their interests and their opinions. So I encourage you to take a look at that. I do have a list that I didn't put on the PowerPoint, but I do have a list that I'm happy to email out with regards to a majority of, or a lot of centers across the country, academic centers mostly, but not all, that have either a patient advocacy board or a community advisory board or patient safety board. So if you're interested in something in your area and you don't really know where to go, I'm happy for you to email me, and I can tell you if I know of something that's in that area, or if I know somebody that could lead you in that direction. As far as community advisory boards for our investigators, I encourage you to find one maybe that's even already established that you can tap into, so you don't have to reinvent the wheel. So for our community advisory board, we established it for our entire center. So anybody that does research, that's a surgeon scientist that does research here at Monroe Carroll Jr. Children's Hospital, has immediate access to that community advisory board. So if you're writing a grant and you need evaluation of something, they can participate, or an opinion, or if you need a letter of recommendation, support from your community advisory board, or if you want to be able to list them as having, a community advisory board to help you with dissemination and implementation, you've got that. So I encourage you to look for that in your area as well. It's not the easiest thing to gear up. It's not the most difficult either, but it definitely would save you time, and it provides you with an opportunity to have access, again, to your patient and family and community stakeholders. So just a few acknowledgments I wanted to put on here. All of the investigators at Park-Reeves, we work really hard as a group. Our patients and families and community stakeholders are huge in our success. and what drives our decision making for new studies and looking at specific outcomes of interest. So we have to really thank them for all of their participation and support. Stephen Gannon, who is my program director here at in the SOX office, who's also very involved with the Park-Reeves network. Jade, she was a research fellow with me this summer who participated in a lot of what we were doing. And then, of course, my team and ASAP. And that's all. Are there questions that I can answer?
Hello?
Hi.
Yes, we have a couple of questions.
Okay.
So, you know, if I keep the mic on, we're going to, oh, that's good, it's working. But if you start having feedback, you have to refer, okay. I texted you already the questions. They're going to be under your messaging system.
Okay.
I'm going to read you the first one. There are 3 questions. The Park-Reeves study is about pediatric cases with Chiari and Syringomyelia. How do you think it applies to adult Chiari and Syringomyelia cases? Or how can it be extrapolated to that population?
So that's a really great question. I think there's going to be several, I'm going to answer this as a researcher, being the non-clinician on the team. But I think a lot of, from the Park-Reeves network, a lot of the work we're doing is looking at radiographic imaging and ways to evaluate Chiari and Syringomyelia. And I think that's going to be, we're going to be able to extrapolate that or assess our outcomes from the pediatric population as well as, you know, in the adult population. The other really interesting piece of what we're doing is we're capturing a lot of medical and family history. And I think that will be interesting to see if we can extrapolate that into the adult population over time. So what are we finding in the peds world that may make treating and managing adult Chiari 1, more generalizable, or are there things that we can do differently now that we have this medical and social history that we're following these patients further out? Is that something, maybe there's a genetic piece to this that, you know, we're starting to look at, so that may also have relevance. I think the other piece that is interesting that we've not spent a lot of time evaluating yet, but that is coming, I think, is the psychosocial piece of this. So chronic symptoms, you know, over time, and depression, anxiety, reduction in activities for daily living. I think all of we're going to be able to extrapolate that and maybe identify predictors sooner or resources have available for general.
Okay, the second question is similar but not exactly. So I'm going to read this written. Pediatric cases are only a small fraction of the overall Chiari cases. Mm-hmm. Adult cases are much more. Is an adult kind of Park-Reeves study coming up that you know of?
I don't know. I think that this needs, this is a continued discussion among all of the colleagues about needing an adult, Chiari consortium or network of some sort. And I think at the end of the day, of all of those and moving, not just in the pediatric world, but in the adult world, sit down what funding looks like. A lot of what we do, the Park-Reeves is currently funding, and recently PCORI funding, and so a lot of the other research networks are as well, are philanthropic and external funding, and that's going to take us to sit down at the table and come up with some ideas of how do we create an opportunity for either philanthropic or external funding that we can start such a network. But the discussion continues, obviously.
The last question. Last question is, the Park-Reeves data have been fed by many pediatric neurosurgery centers from the United States. Would not be a single center with lots of cases be better than your model?
So I would say no, and I touched on that a couple of times. This is, again, my opinion. But I believe that I think having a single center that has a lot of cases would be great to include. But the value of having multiple centers is that you're able to assess outcomes differently. So you're not dealing with single center bias or single surgeon bias. And so by allowing multiple centers to be involved in assessing those outcomes the same way, and looking at the variation in care and looking at the variation in outcomes, you're able to really start to assess what best practices should look like. And I definitely think that, in my opinion, having a multi-network that has centers from different sizes, private versus academic, U.S. versus other countries involved, is what we need to be doing. I believe that it's it's really important for us to come together as a group and not be singled out and only look at one center. I really do believe that the model that we're working in and working towards, as far as expanding even other neurosurgical procedures, looking as networks and as multi-institutional centers, I think is relevant for what we're trying to accomplish.
So thank you very much. There are no further questions. We are all very grateful for the participation of Dr. Shannon as a representative of the Park-Reeves study. The Park-Reeves study has been mentioned numerous times during this conference, as it should be. And I guess we're going to hear more and read more from your center, and we're going to have more cooperations to go in the future. Thank you very much.
Great, thank you.